We really appreciate it and appreciate that you are willing to meet remotely during this viral outbreak we're having in the state of California. So we're 2 minutes to start time. I'm sure a lot of people are working through signing on to Zoom for the very first time. This has been quite a just-in-time learning operation for our team. And in fact, we have for a couple of years now been talking about trying to be able to live webcast our events so that people who can't make it physically to our meetings, which now occur in 4 regions across California, would be able to participate remotely from their offices. We still haven't figured out how to do that, but we're working with the California Department of Public Health to do that for our June meeting. We're hoping we'll be back together certainly by then for our Capital Region University Best Practices on June 8th. Cardiologist Joe Skye from Travis Air Force Base is going to be talking about a different angle of these guidelines that we'll be discussing today. And I see that we have Bob Thurman and Melba Hinojosa online with us from the California Department of Public Health now, and they will be working with our team and the Sierra Health Foundation to try to get the technology to work to be able to live webcast from that meeting that will be in person, we hope, on June 8th at Sierra Health Foundation. So with that, I would like to say it's now noon, and I will hand the meeting over to our wonderful chairman, Dr. William J. Bommer, cardiologist, UC Davis, and leader of our Capital Region group, and on the executive committee of the American College of Cardiology. Dr. Bommer, I will mute myself, and thank you so much for leading this virtual meeting.
Well, welcome everyone to our first remote program for University Best Practices and the RightCare initiative. This was a short-term decision we made about a week and a half ago based on evidence that we had that there was an increasing prevalence of a virus that has obviously continued to expand. In today's program, we're going to touch briefly on the COVID-19 endemic or pandemic, depending on what you call it at this point in time, and its relationship to our actual predetermined topic today, which was novel strategies for reducing cardiovascular disease, with our speaker, Dr. Nathan Wong. So we added this because actually COVID-19 plays a significant part in individuals with existing cardiovascular disease, and we thought it was relevant to that. So we would like to proceed and initially discuss some manifestations of the COVID-19 endemic or pandemic and its relationship to our patients in reducing cardiovascular risk and their risk for acquiring complications from this. Brian, next slide. So what the topic is, go back to the title if you could, right there. So the topic is COVID-19, which is the determined disease process of this coronavirus. It was obviously named for the year 19 when it first appeared, and it does have influence on cardiovascular mortality, cardiovascular complications, And we wanted to discuss a little bit. We do have some information about influenza and its relationship with cardiovascular events. So we wanted to combine those a little bit together briefly at the introduction of this program. Next slide. So basically COVID-19, which is the clinical disease description of it, is obviously an ongoing endemic, which has been recently classified as pandemic based on influence and spread initially in China, in the province of China that is now spread throughout China and is spread throughout all continents of the US with the exception of Antarctica, has been associated with between a 2 and a 3.5% mortality in different areas where it's affected those individuals. And because it's a new or novel virus, we do not have any immune resistance to it at this time, so it seems to spread relatively quickly throughout many countries at this time. Fortunately for us, about 80% of us that will be infected by it will probably have a relatively mild or moderate involvement, which will not lead to serious complications or death at that time. However, we do see a mortality, and we'll talk about it in individuals who are older. Certainly 70-year-olds have about a 14% mortality, and those who are 8% for those who are 70 to 79, and up to 14.8% mortality in those over 80 in the Chinese reporting for it. We'll discuss some of the other aspects and risk factors a little bit later in this talk. Next slide. So that being the case, we didn't want to focus entirely on COVID-19 because in a relationship to the other things that we are faced with for our patients, it is still relatively small as far as its influence. We do know, and these numbers are updated all of the time, that there are now about 22 deaths from COVID-19, so that number is going up. And the number of cases involved in the U.S. is continuing to go up, is over 550 at this time. So that number continues to shoot up. As often as we update this chart, it gets changed at that time. But it shows you that it's a relatively small incidence and death rate compared to influenza, which is on the left of it, which led to about 34,000 deaths in the last year of influenza. So it's small in comparison to influenza and certainly small in comparison to stroke and heart disease, where the incidence and mortality are shown to the left of it. So it's important to focus on this and its rise, but let's not forget the overwhelming mortality and death rate associated with stroke and heart disease in the U.S. and the increased mortality that we've already seen with influenza. Next slide. This slide again just shows the mortality in proportion, and COVID-19 overall deaths are still small. The name of the actual virus is called SARS-CoV-2 and is obviously a relationship or a modification of the original SARS virus that went around several years ago for that. Again, 22 cases is the U.S. mortality at this point. Worldwide, there are thousands of cases of mortality at this point in time. So it is increasing as we speak about it. Next slide. And again, this just shows in the columns on the right that we do have treatments and prevention for both cardiovascular disease, stroke, and influenza. And Dr. Wong is going to focus clearly on ways of further preventing cardiovascular disease and stroke as we go on. We do have therapies that are effective even if you've had a heart attack or stroke that are and have been well proven in many trials. We do have the same for influenza, and we do have for both prevention, relatively successful vaccine in the neighborhood of 50 to 70% success rate for that, and therapies, should you come down with it, in the first 48 hours for treatment. But in the area of COVID-19 on the top, or the SARS-CoV-2 virus, we as yet have no prevention available for medicine, and we have untested antidotes or treatments. If you come down with it acutely, it requires mostly supportive therapy at that time. And our best prevention at this point in time happens to be hygiene and quarantine rather than a specific medical therapy or vaccination. Next slide. So we had written an article about RightCare Initiative and some things to practice. Those are highlighted in red here. So basic hygiene is involved with covering your cough and sneeze to prevent droplet spread. Washing hands where contact is important, and certainly spending more time and diligence in washing hands appears to be important. And reduce shaking hands or communicating by touching your face or shaking hands with others. Next slide. Flu shot's still important, not that it's going to prevent COVID-19, but again, influenza still carries a higher mortality and higher prevalence than COVID-19, so let's not forget about treatment prevention for influenza. Next slide. Monitoring temperature is a way of indicating this presence of this disease. If you have a viral syndrome and you have a temperature, then you would potentially be at risk for this disease. We also have tests that are becoming available that would be available through your local health department and authorized by the CDC for this. Initially, they were not available. They're now becoming more available as other suppliers are entering into the chain. Next slide. And realize that the only effective therapy that we have right now is hygiene and quarantine. So if you're quarantined, you may be responsible for 2 weeks of keeping track of yourself and maintaining yourself. So supplies that would be adequate for 2 weeks are going to be required if you're going to do self-quarantine to accomplish that. Next slide. And obviously, don't forget, as we said, the other more prevalent and more lethal diseases that are out there today, including cardiovascular disease and stroke, as well as influenza. So monitoring those numbers is important, and Dr. Wong will focus on those aspects and our improvements in therapy and prevention for that today. Next slide. So COVID-19 is shown here. Why does it affect the heart? Why are we concerned with it? Well, it does appear that the COVID-19 virus is involved and gets involved in the plaque of atherosclerosis. It appears to be present in the plaque in animal studies that have been done for it, and is associated with a severe inflammatory response. Severe inflammatory areas involving or near or adjacent to a plaque can lead to instability of the plaque and perhaps plaque rupture, and that may be the responsible pathophysiology for an increase of acute coronary syndromes that has been seen with COVID-19 involvement. Second, the virus does get into the heart, and myocardial depression from either the proteins or the involvement and compromise of the cells has been seen. So heart failure is a recognized complication of COVID-19. And lastly, unrecognized arrhythmias, both ventricular and atrial, have been associated with acute inflammation and have been documented with COVID-19. So there is a heart failure, arrhythmia, and acute coronary or plaque rupture etiology of some of its increased event rate in patients with cardiovascular disease. Next slide. So because of this, we now have hospitalized reports from patients with COVID-19. We know that about 17% of patients with this disease have developed significant cardiac arrhythmias. About 7% had acute cardiac injury, and there are other complications that are seen as well in this, including the development of myocardial infarction, myocarditis, and cardiac arrest. And with any acute illness, obviously it puts stress on the heart, and we do see demand ischemia, and the type 2 demand ischemia myocardial infarctions have been described with this entity. So it does involve those in our patients for that. We realize that cardiologists have to be prepared to handle both those standard complications. We've all seen ACS, heart failure, and arrhythmias before, so we should be treating those similar to how we've been treating them in other viral diseases for that. We have to realize that some patients may present with severe symptoms. In cardiology has always been asked to come in when we need to go on extracorporeal circulatory support for the patient compromised with very severe respiratory or cardiopulmonary disease for that. ACC, these are American College of Cardiology recommendations, is that for the individual with heart failure or arrhythmias or EKG changes, echo may be useful to determine how involved the cardiac system is, as evidenced by ejection fraction and other parameters. Next slide. For the clinical cases that have been reported at this point in time, we do have a mortality of about 2.3%, as high as 3 or 4% in some other populations that have been seen. Again, to repeat, most patients have a mild or moderate disease, but individuals who are older, over 70 years of age, and over 80 years of age have up to about a 15% mortality associated with it. So age is a significant risk factor for the disease. And if we look at the bottom of the slide here, we can see that things as seemingly innocuous as hypertension do triple the mortality rate up to 6% with just hypertension, 10.5% for cardiovascular disease, 7% for diabetes, and respiratory disease, it goes up to 6%. So pre-existing cardiovascular or pulmonary disease significantly raises the risk of a lethal or fatal event from infection from this virus. Next slide. So based on that, the American College of Cardiology just this weekend has made plans for allowing us to make recommendations. These recommendations are to try to isolate your patients when they come in so you don't infect other patients that come in with it. Obviously, recommending current recommendations for vaccination for pneumonia and flu are certainly there. Where there are, and there are certainly areas where there are outbreaks, the recommendation is to avoid office visits or unnecessary visits. So the recommendation is to go to transphonic or telemedicine for treating your patients for this. So this is really the first time ACC has said stay away from a personal visit at this point in time because of the risk, and we're going to try to go indirectly contacting the patient through telemedicine or some other phone call conversation with the patient. And lastly, for the patient who comes into the ER, you may well know if you come in with a viral situation and you look sick and febrile, our usual approach for this is to start 1 or 2 liters of fluid infusion on that patient in the ER. In this particular case with a pre-existing heart failure, we have to be careful and cautious about that, to constantly assess fluid volume in that patient, because we may overwhelm these patients and put them into worse heart failure by following the standard precautions or treatment modalities for treating an acute viral syndrome. So be cautious of that and be aware if they come in with a history of heart failure, we have to tell the ER physicians to back off or assess fluid status before actually running in liters of fluid, as we often do in this case. And lastly, it's important to maintain immunologic health by maintaining good sleeping, eating, and stress management in our patients before they acquire the virus. Next slide. So this is actually the virus as it sits here. You'll see the spikes sticking out from it. Those spikes actually, how do they get into our cells in our body? They attach to the angiotensin receptor. So many of the cells in our body and in our vascular system have an angiotensin receptor that sits on the surface of the cell. These spikes interact and link to them directly. That linkage allows these virus particles to pull themselves or invaginate into the cell, then turning on the RNA in the cell to make the cell make more copies of this virus. So it actually comes in through the angiotensin receptor on our cardiovascular and vascular cells. Next slide. So what I've shown here is that this is not our first rodeo with dealing with a virus. The virus pictures shown on the top are highly lethal viruses that have been around mammals for years and years. They include things like, on the left, rabies, smallpox, HIV, and Ebola on the top. These are viruses with 90 to 100% fatality rates. So they were highly lethal and remain highly lethal at this time. The next level, rotavirus, dengue, hantavirus, and Marburg viruses still have a much higher mortality than we've seen with the COVID-19, 50 to 80% in that population. As we get to the bottom, we're getting to more of the viruses that are similar to COVID-19, and you can see similar projectiles on the side of them. And to the right is influenza. Influenza is obviously prevalent throughout the world, but has a much lower mortality than these other entities. The mortality is about 0.1% in most populations. And so where is COVID-19? COVID-19 is in the middle of these mortalities for lethality. It is approximately 20 times more lethal than influenza, but at the same time, 20 times less lethal than our most lethal viruses. So right about in the middle in a log scale is the lethality of COVID-19. Next slide. Here is the infection rate for these viruses that we have been dealing with. If you look on the top for MERS and influenza, they're less infectious with a chance of the single orange individual of infecting about 1 or 1.5 individuals from their contact. COVID-19, the idea from China is that you will infect about 2.5 people from one source at that point. This infection rate is greater than influenza, and that's why we're seeing an increase in spread of it at this time, but is nowhere near as serious as to what the infection rate is from rubella, smallpox, or measles, where we see the RO rate is in the teens with that. So those are much more highly infectious etiologies. So what does this mean? It means that COVID-19 is moderate in infection rate. It's moderate in lethality at this point in time. Those two aspects allow it to actually spread because it doesn't kill all of its hosts or sources, and it remains infectious at this time. So we expect COVID-19 to continue to increase and spread throughout the world. Next slide. And that evidence is seen here. If you look, the slides that the dots that are red and pink show the mortality and spread in China at this time, where it initially started off. The blue or the aqua and blue are the mortality and the infection rates in the rest of the world. Now, of interest, you see, is that I don't know if you were able to get on there, Brian, the two words I added to that slide, hygiene and quarantine are the two ways that China has looked at. If you look at when they added hygiene and quarantine, you can see that the pink and the red skies or dots have sort of leveled off a little bit in China based on their implementation of hygiene and quarantine. Whereas the blue dots, reflecting the incidence in the rest of the world, have actually continued to rise with a steep rise at this point in time. And again, all we have to offer at this time is hygiene and quarantine to try to stop that. And you can see at this point in the rest of the world, we may not be able to quarantine as effectively as they were able to in China. And so we expect and see a rapid increase or rise in both the mortality rate and the infection rate in the rest of the world. And with that, we'll have to deal on a day-to-day basis as we go on and face this endemic or pandemic in the rest of the world. Remembering that this mortality and this risk affects primarily older individuals and especially people with cardiovascular disease. I'd like to turn now to our speaker, Dr. Wong, who will be presenting further ways of reducing cardiovascular disease in these individuals as it relates to prevalent disease in our society, as well as the risk that is presented by viral diseases in these individuals as well. Nathan is an old friend. He happens to be a mountaineer and skier and was supposed to be up here this afternoon at this time enjoying skiing and mountaineering, but because of the virus is confined to self-quarantine at this point in time at UC Irvine in his office. And we are practicing that for RightCare to reduce any spread of disease by the RightCare initiative. He is an eminent cardiovascular epidemiologist with training. He is on the faculty and staff at UCLA and UC Irvine. For that, he is the past president of the American Society for Preventive Cardiology and the Pacific Lipid Association. Both important aspects to his presentation that will be today for that. He has written and published numerously publications on this. And I first met Nathan probably about 30 years ago. We were co-investigators in a cardiovascular health study. He has continued to perform in an outstanding way in all aspects and has been an expert from day one on cardiovascular disease and prevention. And it is my privilege to introduce him today to talk to us about his aspects of cardiovascular prevention and novel ways, of which he is certainly the expert today. Nathan, I turn it over to you.
Okay, thank you very much, Bill. And I think, Hattie, you need to unmute me. Am I unmuted?
Yes, you are. We currently hear you.
Oh, okay. Okay, wonderful. So, I'd like to again to thank Dr. Bommer as well as Dr. Ivy and the rest of the RightCare initiative leadership team for the great opportunity to present to your group today. So as Dr. Bommer mentioned, what I'm going to be doing here is really focusing on some of the most important novel strategies that have been shown to really help further prevent cardiovascular disease. We've had a lot of great therapies out there, but the problem is a lot of people still suffer cardiovascular events. And this, in the last few years, there's been some amazing new therapies and actually clinical trials that have helped further make a dent in what we call this persistent or residual risk. So if we can go to the next slide. These are my disclosures. Next. So we're briefly going to talk about first cardiovascular risk assessment, which is really the foundation for preventive cardiology. We'll then launch into briefly covering the current lifestyle management guidelines and really spend a fair amount of our time talking about the cholesterol management guidelines and newer therapies that have just become available over the last few years that are really making a significant impact on reducing this persistent risk. Also part of this are the newer evidence-based therapies for actually diabetes that is really one of the really hot areas. And then we'll actually end by actually briefly covering some of the evidence that relates influenza vaccine to cardiovascular risk reduction, and then briefly covering also a very novel, what I think is probably the closest thing that we'll have to a vaccination for atherosclerosis, potentially coming out as early as next year. So let's go to the next slide, please. Okay, so this, many of you have seen this before. Cardiovascular disease accounts for 1 out of every 3 deaths in the United States, and there's a cardiovascular disease death every 40 seconds in the United States, and we have about 90 million American adults living with some form of cardiovascular disease. And this is really the largest contributor to our healthcare dollars, currently over $300 billion every year. But by the year 2030, this is expected to be more than $1 trillion. So clearly, this is unsustainable, and the focus going forward really has to be on prevention. If we go to the next slide, this kind of pictorially displays this, and the fact that we're constantly trying to clean up messes that perhaps could have been prevented. So this is really the whole focus of what we're talking about here. Next. And I think, as most people understand, cardiovascular disease has a multifactorial etiology, and there are numerous both modifiable and unmodifiable risk factors that contribute to the development of atherosclerosis, eventually leading to a cardiovascular event, whether it's a myocardial infarction or a stroke. There are also unknown risk factors. However, what we do thus have so far seems to explain probably 2/3 to 3/4 of cardiovascular events. Next. And this slide I always like to show because it really gives you an appreciation as to the top leading causes of death in the world. And many of us don't realize that actually it's elevated blood pressure is responsible for some 7 million deaths annually in the world, followed by tobacco use, high blood glucose, such as diabetes and pre-diabetes, physical inactivity, overweight and obesity, and then high cholesterol. So the top 6 leading causes of death in the world are cardiometabolic in nature, and many of these are increasing dramatically in both developing as well as developed countries. Next. One thing very important to our latest prevention guidelines is the real focus on a team-based care approach. So it's not just the physician, but very important that we have the nurse or nurse practitioner, as well as lifestyle management experts such as dietitians, as well as exercise physiologists, and they all need to be involved in this prevention effort. And also shared decision making, so that the decision should not just be up to the healthcare provider, but one always needs to discuss with their patient what are the best ways to prevent disease and to really come up with a joint decision together with the patient. Finally, social determinants of health are really underappreciated, and there's still a great need for more data on this, but issues such as how, depending on what neighborhood you live in, and if there's, for example, access to, walkways or actually bicycle ways to exercise or not, how safe it is to exercise, how readily available healthy foods are, or do you live in a food desert? So there's a lot of social determinants of health that need to be further considered. Next. So I like to show this. This is my mentor from the Framingham Heart Study, probably the most famous medical director of the longest running heart disease study in the world. And he was one of my advisors on my PhD work at Yale going back some 35 years. And he, in 1961, ironically the year that I was born, coined the term risk factors, right? So this is a term that's used in virtually every field of medicine today. And he came up with this paper that described the first 6-year follow-up experience of the Framingham Heart Study, showing that key risk factors, namely hypertension, hypercholesterolemia, and left ventricular hypertrophy in this particular paper predicted risk. And he noted that risk functions back in 1976, he noted that risk functions can provide an economic and efficient method of identifying persons at high cardiovascular risk who may need more intensive treatment. So he was far ahead of his time in something that has really taken probably 40 years to promulgate the medical community. Next. And currently, what is recommended as a starting point in understanding how aggressively we should treat people is to really know the patient's risk. So you have to know their baseline risk. There's this risk calculator that is available, I believe, at the website that seems to be cut off on my screen, but you can also download this if you just write in ASCVD risk estimator plus into your store on your smartphone. you can download this. And it's recommended really as a starting point, and it gives you the 10-year hard atherosclerotic cardiovascular disease risk, which is basically fatal or non-fatal myocardial infarction or stroke for people 40 to 79, and then a lifetime risk for people 20 to 59. And the point here is we want you to use this to really promote that patient-provider risk discussion to really find out what are the best ways to reduce cardiovascular risk. And now there's been, of course, debate as to how accurate this is. It was developed in populations that are several decades old. Nonetheless, it's recommended as a starting point, and we're going to talk about, well, what else should you maybe consider, because this is not the end-all in the story. Now, on the right hand of the slide, it shows what is a very useful sort of counseling tool. You can actually, for example, in a smoker, take away the smoking aspect and basically show the patient, well, what happens to your risk if you maybe stop smoking, or if you lower your blood pressure by 20 points. So it's a very useful tool to really help educate the patient about what are the best ways to reduce their risk. Next. So when you do this calculator, you're going to get a 10-year risk, and basically these are the 4 categories of risk: low, borderline, intermediate, and high. If you're at low risk, generally in most people, lifestyle modification alone is sufficient. If you're at high risk, you should both be on lifestyle and evidence-based preventive therapies at the same time. If you go to the next slide, you'll see that if you're in the borderline and intermediate risk category, this is where consideration of these risk-enhancing factors is most important. So I always say that when you're trying to define a premature family history, it's not just a simple yes/no answer, but you need to do a complete history of the of all first-degree relatives, and it's a number of male relatives under the age of 55 or female relatives under the age of 65 that matter. The more affected first-degree relatives with an early cardiovascular event or procedure, the higher your patient's risk will be. Also, persistently elevated cholesterol levels. So if your LDL cholesterol is 160 or higher. Now note it says 160 to 189 because people that are 190 or higher for LDL are really placed into a different category. We don't recommend doing the risk score in those people. They have suspected familial hypercholesterolemia, which is an autosomal dominant condition that is highly unrecognized, yet quite prevalent, more prevalent than many of the genetic diseases we typically think of, such as cystic fibrosis, for example. If people have metabolic syndrome or chronic kidney disease, or certain, now new to the list, are certain inflammatory conditions such as rheumatoid arthritis, HIV or AIDS, history of premature menopause or pregnancy-associated conditions such as preeclampsia or gestational diabetes. These all can increase the patient's risk and help inform the decision to initiate treatment in such borderline or intermediate risk people. Also, high-risk races or ethnicities, particularly South Asians or African Americans, Native Americans, are certain groups that are particularly high risk. And then if you have persistently elevated triglycerides, and there are data showing that actually your risk may begin even at 100 or higher triglyceride levels. And we're going to get back to this a little bit later in the talk. And then if you have certain things already measured, like elevated C-reactive protein or lipoprotein little a, apolipoprotein B, or if you have an ankle brachial index that is considered abnormal under less than 0.9, remember, is diagnostic of peripheral arterial disease, then these patients may, so if you have one or more of these risk-enhancing factors, then it can help inform the clinician and the patient about the urgency to start or intensify treatment, in particular statin treatment. These really came from the cholesterol management guidelines. Next slide. And then if uncertainty still remains, you can consider the coronary calcium score, which is something that's been dear to my heart. I've been involved in research in this pretty much from the beginning about 30 years ago. If we go to the next slide, it tells you that if you have a 0 calcium score, what the risk is that you actually, because you have something called a warranty, a 0 calcium score indicates that you have a 10 to 15 year warranty against getting a cardiovascular event. You have a very, very low risk. This is below the threshold of statin benefits. So these guidelines for the first time suggest that you may even consider avoiding or postponing drug therapy, even if you are in that intermediate risk range and have moderately elevated cholesterol levels. If you're above 100 or greater than the 75th percentile, then consider statin therapy. These people clearly will benefit because the absolute risk is higher in such individuals. If you're in that 1 to 99 range, this is where you could consider therapy or you could postpone it. So we're kind of on the fence because you're kind of in that gray zone where you may or may not get benefit, and thus other risk-enhancing factors should really be considered in making that decision. Next. These are some of the data that derived from a paper that my colleague Khurram Nasir and others published in JACC in 2015 from the MESA study, basically showing that if you are below that 20% risk, so the first 3 sets of bars and you have a calcium score of 0, your event rates are actually lower than the 7.5% rate that is considered the threshold for actually benefit. Whereas if the score is above 100, then you're pretty much at or above that 7.5% rate, thus warranting the concurrent use of statin therapy. Next. So these are just some early data that we published now going back 20 years. This was one of the first prospective follow-up studies showing that the higher the calcium score, the higher the cardiovascular event risk. It's certainly come a long way since these early studies. If you go to the next slide, one of the most recent ones, which I participated in with Matt Budoff, also from the MESA study, like many others, shows that what was unique here was that regardless of the 4 ethnic groups that were included in MESA, whites, Chinese, blacks, or Hispanics, that if you had a calcium score of greater than 100, you had that 10-year event rate that exceeded the threshold for benefit from statins of 7.5%. So this really helps support the current guidelines that if your calcium score is above 100, regardless of your ethnicity, you are at risk where statins have been shown to benefit. Next. So a little bit about lifestyle. This is, again, a whole talk. I can recommend some great speakers for you to cover this in much more detail. But if we just go by what the guidelines recommend, next slide. You've pretty much heard of the DASH, or dietary approaches to stop hypertension diet, very similar to the Mediterranean diet, focusing on a high intake of plant-based foods with relatively minimal use of meats. And if you do use lean meats, use not low-fat based ones, also using non-tropical plant-based oils instead of animal fats, and of course limiting high-fat red meat. And in particular, what's harmful is processed red meat, and of course sugar and sugar-sweetened beverages. You've heard some stuff in the media lately about dietary cholesterol again, and yeah, it's probably true that one egg a day that has about 200 to 250 milligrams, if that's your main source of cholesterol, that's not a quantity that's going to hurt you. But the problem is that many Americans are consuming too much saturated fat, such as from meats, luncheon meats, things like that, and as well as other dairy products, and that can certainly raise your cholesterol, probably more than one egg a day will. Next. And then physical activity, 150 minutes, moderate intensity, or 75 minutes vigorous intensity physical activity. And ideally, the point here is to try to incorporate physical activity into your daily routine, right? So what we call incidental physical activity is, for example, parking further away from the entrance of the store, so you get that extra amount of exercise. Next. And these are different types of exercises that are considered moderate, such as brisk walking, biking, ballroom dancing, or vigorous, jogging, running, bicycle riding, swimming laps, etc. Next. So this is really the summary diagram for the current cholesterol management guidelines in primary prevention, right? So this is people without known atherosclerotic cardiovascular disease. We already talked about how you get the 4 different risk groups when you do the risk calculator. And if you're in the middle 2 groups, you can consider one of those risk enhancers. And if the risk decision is still uncertain, consider the coronary calcium score. If you are at high risk, one should consider a statin to reduce the LDL by at least 50%. This is the premise of what we call a high-intensity statin. If you have diabetes, you should at least be on a moderate-intensity statin, but also do that risk calculator, because if you have 2 or more risk factors, or you have greater than 20% risk, we really want to see those people on a higher intensity statin and trying to get the LDL down by at least 50%. So remember that in 2013, we took away initiation LDL levels and target LDL levels, with the exception of this 190 or higher group, which is suggestive of familial hypercholesterolemia, needs further evaluation, and should be on a high intensity statin. But if you're, but the idea is the other groups, we really took away, we took away initiation levels and target levels in 2013, because the guidelines committee really felt that there was no evidence to support a certain target, such as less than 100 or less than 70. So we are now really focusing on statin intensities and treating the patient according to their overall risk and not just according to their LDL cholesterol number. Next. And these are, without spending too much time on this slide, basically these are the dosages of atorvastatin and rosuvastatin that constitute a high intensity statin designed to lower the LDL by at least 50%. Most of the others fit in the category of moderate intensity statin designed to lower the LDL by 30 to 50%. Next slide. So how about diabetes? So I already mentioned that these people should at least be on a moderate intensity statin, and if you have higher risk, as shown on the bottom here, it's reasonable to add ezetimibe to make sure that you're getting the LDL lowered by at least 50%. Next. And then also, for the first time, we have guidance in younger people with diabetes. So here you can't really do that risk score, but the idea here is that if you have certain factors such as long duration of diabetes, albuminuria, or evidence of CKD, retinopathy, neuropathy, or an ankle-brachial index under 0.9, then it may be reasonable to initiate statin therapy. So these are in the younger people with diabetes, because remember, they're going to have a long a large lifetime risk. Next. So next here we have the people with clinical ASCVD, so the secondary prevention group. And remember, in such individuals, we also don't do the risk calculator. The risk calculator is really just for primary prevention and estimating risk in people who have not already had an event. But the main point of this slide here is to show you that and new to the recent guidelines is we don't treat everybody with ASCVD the same. We have high-risk people, or we have those who are at very high risk, and those who are not at very high risk. And without spending too much time talking about all the little boxes here, the main difference between the two is that if you are at very high risk and your LDL is still 70 or higher after statin and ezetimibe, then a PCSK9 inhibitor, which I'm going to talk about in a minute, is considered to be reasonable. If you're not at very high risk, then we only recommend adding ezetimibe to try to get that LDL below 70. So let's go to the next slide, because this defines how do we categorize people into very high risk or not. So for very high risk, you need to have at least 2 of these major ASCVD events. So recent acute coronary syndrome, history of MI, history of ischemic stroke, or symptomatic peripheral arterial disease, or 1 major event and multiple high-risk conditions. If we go to the next slide, that lists the multiple high-risk conditions. So 2 or more of those, which includes things like being 65 and over, diabetes, hypertension, prior CABG or PCI, heterozygous FH, hypertension, CKD, current cigarette smoking, persistently elevated LDL, or history of heart failure. So remember, 2 or more of those major CVD conditions, or 1 of those and 2 or more of these, constitutes the very high-risk patient. Next slide. So does it really matter? Why do we want to identify, why do we want to try to make the distinction between high risk and very high risk. So I wrote this editorial, which I'm not going to read for you, but you can look it up in JAC a few months ago, that kind of goes through the rationale. The fact of the matter is, based on this was a commentary that I wrote on a paper from the Muntner group that showed that people who are classified as very high risk actually have a threefold greater risk of a recurrent event than those who are not classified at very high risk. So that's why it's important. And in fact, the people with 2 or more major CVD conditions actually have a 5-fold greater risk. So let's go to the next slide, because now we talk about certain therapies that have now been shown to benefit the very high-risk people, perhaps better than the not at very high-risk people. So here we have, so the PCSK9 monoclonal antibodies became available now about 4 years ago, and what these do is they block something called PCSK9, or proprotein convertase subtilistin kexin type 9, which is a protease of about 700 amino acids. And what that does is that actually, and those are those kind of light brown things, right, that you can see. What those normally do is they actually destroy the LDL particle receptor complex. The receptors are these squiggly little things. The receptors are needed, remember, to keep the cholesterol under control. And you want those LDL receptors to recycle about every 15 minutes, and they process and destroy the LDL particles, keeping the plasma cholesterol under control. But what happens with PCSK9 is it destroys that whole complex, thereby you get fewer LDL receptors and you get very high LDL cholesterol levels. So a monoclonal antibody actually, if you go to the next slide, has been shown to reduce LDL cholesterol another 60% beyond statin therapy. And until these drugs, we never saw such low LDL cholesterol levels, even from the statin trials. It was very infrequent. In this major trial, the median LDL dropped to 30, and this is on top of moderate or high intensity statin in most cases. But what's always important is you can't assume that lowering the cholesterol is going to be a good thing. The FDA now requires, and most clinicians require, proof that you're going to see further incremental reduction in cardiovascular events. So if you go to the next slide, you'll see that there was a 15% relative risk reduction or hazard ratio of 0.85 from this major trial that went for 2.2 years. Most of us expected somewhat of a greater risk reduction, but we do realize that that when you're talking about an anti-atherosclerosis therapy, you don't start seeing benefit until about a year or year and a half, and the curves continue to diverge. In fact, the statin trials, some of the statin trials went on for 5 years and showed closer to a 30% risk reduction, which one could project if had this trial continued longer. But nevertheless, we're left with what we have, right? This is the actual published result, and it's speculative to go beyond that. Next. There was a subgroup of patients whose LDL got down to even below 10. Can you imagine? Below 10 milligram per deciliter. And these people showed additional benefit without any safety concerns, at least for the period of time that was studied in this trial, which remember was a median follow-up of about 2.2 years. So it's going to be very important to see whether there still is no safety signal of harm if we continue following these patients for 5 or even 10 years who have attained very, very low levels of LDL cholesterol. There was, the investigators were so bright that they even designed a cognitive function study involving objective measures of cognitive function, and that also showed no signal of harm in the people who were in the treated versus untreated group. So at least pharmacologic lowering of LDL down to even very low levels, at least for the several years of data that we now have, seems to not be harmful. Next slide. What we also learned from later analysis of these trials was that people who maybe had multiple MIs, right, these are higher risk than those who only had one MI, that they derived greater benefit, right? A much lower number needed to treat here of 38 compared to people with only one prior MI. And then next slide. Similarly, in people with multi-vessel disease, as opposed to only single vessel disease, these people are also at higher baseline risk, and in Fourier had a greater relative risk reduction. So one got a very favorable number needed to treat in this case. And then if you go to the next slide, we can talk about the other PCSK9, alirocumab, briefly. They also had an outcomes trial. That showed virtually the same result, a 15% relative risk reduction after about almost 4 years of follow-up. These people were actually higher risk to begin with because they had to have had an acute coronary syndrome within a year. And if you go to the next slide, you'll see that there were some other analyses, and here the very high risk people or people with polyvascular disease also benefited much more than people who had single vessel disease or people who are not at very high risk. So these data are certainly supportive and was the impetus for the most recent cholesterol guidelines, really trying to reserve these therapies that until recently were quite expensive. They had about almost a 60% price reduction towards the end of last year, which really helped, but perhaps it was not enough too late. So, so there is still underutilization of these drugs. They are a little easier to get pre-authorization than they were before, but still the baggage that they carried from being very expensive initially still remains. So next slide. So what about hypertriglyceridemia? So this is a this is a problem that still remains, and in fact might even be getting worse with the continuing increase in the obesity epidemic that we're seeing in the United States. And what we're finding from some data that we recently published is that despite statin therapy, which is the has been the still the gold standard for dealing with elevated levels of triglycerides, because other medications such as niacin and fibrates have failed in their clinical trials. But despite statin therapy, we're still finding about 25 to 30% of US adults still have elevated triglyceride levels. So part of what we call this persistent or residual risk is due to this problem of persistently elevated triglyceride levels despite our available therapies. Now, if we go to the next slide, we can see that just to briefly review, there were several fibrate trials that were done a number of years ago that failed their primary endpoints for various reasons, whether they included people with high enough triglycerides or low enough HDL remains a question. What's interesting is if you look at a post hoc analysis of these trials, you do see that there's significant benefit in the subgroup with high triglycerides and low HDL. So the idea is perhaps these drugs worked, but only in people who actually had what we call this metabolic syndrome dyslipidemia. Next. And then the niacin trials, both aim high, and if you can click on the slide again or go to the next one, as well as HPS to Thrive, these were the major trials that involve niacin, which not only lowers triglycerides substantially, but also raises HDL. However, these were completely negative due to various reasons, perhaps design issues, tolerability issues. One can go on and on about maybe why they were not positive, but the fact is they failed. So this is why we don't see much use of niacin anymore as we did perhaps 15 or 20 years ago. Next. So, however, though, there's a lot of interest in fish oil dietary supplements, which by and large do lower triglycerides, but to varying amounts. And some data, like in the UK, show that almost a third of adults are taking fish oils. Some other data in the United States suggests it may be, around 10%. Maybe it's even higher now over recent years. So this is a huge market. If we go to the next slide. So this slide, though, tells us, though, that perhaps the public is being greatly misled, because what's not appreciated is that many of these lead-in fish oil supplements that you get from the grocery store or the nutrition store have a fairly high amount of saturated fat and other fats. So why would you want to recommend to your patients or take yourself products that contain saturated fat? And in some cases, it's been noted that to take the recommended amount of fish oil supplement pills to get enough EPA or DHA, that you would get as much saturated fat in perhaps a large hamburger. So you certainly don't want to be doing that. If we go to the next slide, one will also see that a number of these dietary supplements actually exceed thresholds for allowable oxidation. So they are already oxidized. So this is a big problem. You don't want to be consuming fish oil that is already oxidized, because this is going to perhaps have could have a negative effect on your lipids and their ability to enter the actually arteries. Then if you were dealing with a product that was not oxidized. So if we go to the next slide, And you can click several times here so we get the whole list. Okay, that's good. So, so the point here is that none of these supplements are FDA approved, for one, and there are numerous impurities, as we already discussed. And most importantly, there is no supplement that has been shown to reduce atherosclerotic cardiovascular disease risk, which is really what we want to see. And many of the clinical trials that have looked at other preparations have failed to show a benefit over recent years. So if we go to the next slide, so that brings us up to Reduce It. So I'm not sure how many people have heard of Reduce It, but this was released now about a year and a half ago at the American Heart Association scientific sessions, and was one of the biggest stories of the decade in cardiovascular medicine. This involved a prescription pure EPA product called icosapent ethyl, and they studied people who either had established cardiovascular disease or diabetes and additional risk factors. And triglycerides did not have to be that high. Actually, the official inclusion criteria was 150 to 499, but because they allowed 10% variation, people could get in if their triglycerides were as low as 135. And importantly, they had to be on stable statin therapy, because remember, when you do clinical trials these days, it has to be on top of the background of standard of care. And this was a standard of care, certainly for these higher risk patients that were studied and Reduce It. And their LDL had to be fairly well controlled between 40 and 100. So if we go to the next slide, the amazing surprise was that there was a huge benefit, a 25% relative risk reduction over the 4.9-year period of treatment. And because these were pretty high-risk people, the absolute risk reduction was 4.8%. So this corresponded to a number needed to treat of 21. So that means that for every 21 patients that you would put on this therapy of 4 grams icosapent ethyl per day, that you would prevent a cardiovascular event, one of these primary endpoints. So that is considered to be highly efficacious. Many times you need 50 or 100 or more patients to be treated to prevent an event. Next slide. I think what was most striking was the consistency in the secondary endpoints. So if you look at this hierarchical testing, it wasn't just the primary composite endpoint, but the secondary MACE endpoint, myocardial infarction, revascularization, cardiovascular death, unstable angina, stroke. All of these were significantly reduced. And you can see, for example, revascularization, which confers a huge cost to the healthcare system, has a 35% risk reduction. Only total mortality did not quite make it, but remember, the trial was not designed to look for mortality differences, and clearly it went in the right direction, and an additional year or so of follow-up would likely have shown a benefit. In fact, what I don't have slides to save time is the USA subgroup data. If you just looked within the USA patients, there tended to be even greater benefits in the primary and several of these other endpoints. And in fact, total mortality was significantly reduced in the USA subgroup. So next slide. So a few months after Reduce It, the American Diabetes Association was the first to jump on the bandwagon and make a clear statement saying that they would give a Class A recommendation for the use of this therapy in people with diabetes who either had ASCVD or other risk factors and triglycerides in the range that was studied. They also noted that data are lacking with other omega-3 fatty acids, which still remains to this day. There was a recent trial of another product that was a 4-gram mixture of EPA and DHA that for various reasons was prematurely discontinued because of lack of efficacy. That was a different product. So next. And I think what really says the most here is that this is now the first such therapy to now be approved by the FDA for the reduction of cardiovascular risk with a slightly broader indication. So it's diabetes and any 2 or more additional risk factors, triglycerides 150 or higher, and not necessarily requiring certain LDL cholesterol levels, but it is considered an adjunct to maximally tolerated statin therapy, which, depending on if the patient is statin intolerant, could be actually zero statin therapy. So this remains the only FDA-approved fish oil product to reduce cardiovascular risk, which is really what we're all about here. Next slide. And one can see maybe how this fits within the armamentarium for risk reduction beyond statin therapy. So here you see as that you have ezetimibe shown in the Improve It study, was studied in people with an acute coronary syndrome within 10 days. PCSK9s, of course, have been studied both in people with stable ASCVD and a recent ACS, so they have the evidence there. But pure EPA, eicosapentaenoic acid, has been studied now not only in people with stable ASCVD, but also diabetes and additional risk factors in primary prevention. So this is really the only therapy in that particular primary prevention group where we have evidence for risk reduction beyond statin therapy. Next. What also is very exciting is the recent FDA approval of bempedoic acid. So this is a new non-statin oral therapy, the first such non-statin oral therapy to be approved in the last 20 years, specifically to lower LDL cholesterol. It acts in the same pathway as a statin, this higher up. Basically, it inhibits something called ATP citrate lyase, and thereby it inhibits the biosynthesis of cholesterol. And both the monotherapy as well as the combination with ezetimibe were approved, this in the last couple of weeks, for people with either known ASCVD or heterozygous FH requiring additional LDL cholesterol lowering. So this is felt to be an important option for people that may not be able to take statins or are not getting enough efficacy from statins. If we go to the next slide, one can see that there's roughly about a 15% reduction in risk from LDL cholesterol. Remember that important to keep in mind is that this therapy, the effects on cardiovascular risk reduction are still unknown. So they are doing a large outcome study, but we're a few years away from knowing whether the LDL cholesterol reduction seen from this particular product is going to lower cardiovascular risk like you do with statins. So that's important to keep in mind whenever thinking about some of these newer therapies. Next. And then the combination therapy here, you get this, looking at the yellow there is the bottom line, you get about a 35% or so LDL cholesterol reduction when combined with ezetimibe. So this is clearly a very important LDL reduction that particularly may be needed in people that are not responding or not tolerating statin therapy alone and are unable to get to what clinicians might feel are the levels they want to see. Next. Okay, let's just go through just a few hot things regarding diabetes that I'm particularly very passionate about. This slide needs really no explanation, just pointing out that we need to realize that diabetes is a cardiovascular condition, okay? It's not just a blood sugar condition, but your patients have to realize that it is a cardiovascular condition. Most people with diabetes will die of either heart disease or stroke, either coronary heart disease, heart failure, or cerebral vascular disease. Next slide. And then I'd like to show this because it tells you that not everybody with diabetes is equal. So there's tremendous heterogeneity in diabetes. So this is why we need to do the risk score. And this is why certain data, such as knowing a coronary calcium score, can be very helpful. This paper that my colleague and I did several years ago shows a 10-fold variation in risk if we go from those with zero calcium to people with a 400 or higher calcium score. Next. And then there were guidelines that supported its use. Also here, this is also something that I wanted to point out because I'm very passionate about this. The point here is that we do a reasonable job with addressing single risk factors. Like, for example, 3/4 of US adults, this is from the ACC-initiated Diabetes Collaborative Registry, which partnered with other organizations. I chair the Research and Publications Committee for this registry. And so we show roughly 3/4 of people are at target for A1C, maybe 70%, well, 40% if you use a lower blood pressure cut point, and half at target for LDL. But look at this, only 22% are at target for all measures, including non-smoking, and it's down to 13% if your blood pressure is, if you use a lower blood pressure target, which is now actually the accepted blood pressure target. So clearly we are doing a poor job with composite risk factor control, and we need to make sure that we have healthcare systems in place to identify those that are not at target for one of these and maybe should be placed on additional therapy. Next. And then this, these data we published shows that if you're at target for all three of these, blood pressure, LDL, and A1C, that you have 60% lower cardiovascular event risk than if you don't have any of these controls. So again, emphasizing the importance of multiple risk factor control. Okay, next here, and I want to try to finish up hopefully in the next 10 minutes so we have time for questions. The Steno-2 trial showed the importance of intensive multifactorial risk reduction. Again, compares to our 60% lower risk that we get from our observational data. Next. So the hot thing in diabetes, and I know you have another speaker scheduled in a few months that may also cover a little bit of this, but I think it's important that maybe some people hear this more than once, because we're still not seeing much utilization of these therapies. These are the GLP-1 receptor agonists and SGLT2 inhibitors are the first classes of anti-diabetic medicines now shown to have cardiovascular benefit, and several are FDA approved for that now. The GLP-1s stimulate insulin release and inhibit glucagon release, thereby reducing blood glucose, and the SGLT2s promote urinary glucose excretion. So have more of a hemodynamic effect, and you get more of a weight and, well, you get more of a effect on heart failure in particular. The GLP-1s may have more of an anti-atherosclerotic effect, however. Next. And the ACC came out with a decision pathway now about 1.5 years ago that said if you have both diabetes and cardiovascular disease, and I was just a reviewer for the revision of this, and they're going to be adding additional risk factors. So it's also primary prevention high risk, and you should consider one of these therapies. And in the next slide, you'll see that there is a listing of different scenarios where one may be preferred over the other, such as clearly an SGLT2 shows benefit in heart failure hospitalization. You don't get that with the GLP-1. Weight loss is going to be greater, though, with the GLP-1. So it all kind of depends on your patient's goals. And then there are, of course, certain contraindications we don't have time to go into today that are also listed here as well. Next. And the primary prevention guidelines also recommends this in patients with multiple risk factors to consider one of these therapies. There's a class 2B recommendation for adults with type 2 diabetes and additional risk factors who require glucose lowering despite initial lifestyle modifications and metformin. It may be reasonable to consider one of these. And next slide has even the most recent ADA standards of care from January. And they now have even a much different approach than they did couple of years ago. Now they can say that initiation of one of these can be considered independent of the current A1C or A1C target. The fact is that these drugs are only modestly lower A1C, about 0.5%. So you might think of them as A1C lowering drugs, but now that many of them are now indicated for cardiovascular risk reduction, they really should be thought of more as cardiovascular drugs. So hence the great interest by the American College of Cardiology and American Heart Association to help educate cardiovascular professionals into their appropriate use. And also, if you're already on some other therapy, consider switching one of those for one of these with proven cardiovascular benefit. Okay, so that's a pretty bold statement too, but the data have been very, very convincing. Next. And I'm going to go through some of these pretty fast. This was the original EMPHA-REG study involving empagliflozin that really got all this on the map going back almost 5 years now. These were in people with pre-existing cardiovascular disease. And on the next slide, it shows its primary outcome on the upper left, a 14% risk reduction, but look at the 38% reduction of cardiovascular death, all-cause mortality of 32%, and heart failure hospitalization of 35%. So this generated a tremendous amount of excitement. And if you go to the next slide, it was then followed by Canvas, which also included people with multiple risk factors, so not just cardiovascular disease. And next slide, one will see that it had a similar 14% risk reduction. And then if you go to the next slide, you'll see that, that it did not reach any of the individual outcomes of cardiovascular death, MI, or stroke, although the composite was significant, but heart failure was consistent with the other drug, with empagliflozin. Next slide. And then the other thing to point out is that these have also been touted, the SGLT2s have also been touted as the next greatest class of renal drugs since the ACE inhibitors and ARBs 15 to 20 years ago. And now you're seeing a plethora of studies looking at renal endpoints. This is just the first one to show that the primary renal outcome of worsening kidney disease was decreased by 30% in people given this drug who had pre-existing mild to moderate CKD of 30 to 90 eGFR. Next. And then also the next greatest class of heart failure drugs too. So here DAPA-HF was presented at the European Society of Cardiology in Paris and recently published, and they showed a 25% risk reduction, 26%, number needed to treat of 21 in heart failure patients for incident CVD death and heart failure. So again, a very exciting time. We now have a newer class of agents that originally was strictly thought of as new diabetes therapies, but now also new kidney disease and new heart failure therapies as well. Next. So then we're into the SGLT2s. Leader was the first to demonstrate benefit. Next slide. In both people with and without cardiovascular disease, a 13% risk reduction. Next slide. And then SUSTAIN-6, also people with and without cardiovascular disease. Next slide. This was designed as a safety trial, but it did show an even greater 26% reduction in the primary outcome and a 39% reduction in stroke. So this is one of the few that has actually shown a reduction in stroke, which is very exciting. Okay, next, and we're just about finished here. A few words about influenza vaccines. Since 2011, in the secondary prevention guidelines, influenza vaccine has been a class 1B recommendation that did not get the press that it deserved, because as Dr. Bommer pointed out earlier, people with cardiovascular disease are at greater risk of other problems and even of getting the flu. So we need to really get our patients to adhere to this guideline. Next. And this was supported by quite a bit of observational study evidence, right? Here you have a large meta-analysis that showed anywhere between 20 and almost 48% reduction in death in people with cardiovascular disease who got a flu vaccination. So this is a substantial benefit in terms of most of these endpoints. But how does the clinical trial evidence stack up? So let's go to the next slide, because clinical trials, of course, is what we got to hang our hat on. And here you have 6 randomized trials of almost 7,000 patients. And overall, there was a pretty substantial risk reduction, as you can see in the published trials. But what's important was that actually the people who benefited were those who had a recent acute coronary syndrome. So again, the higher risk people seem to benefit the most. So that's an important take-home message. Not to say that the lower risk people should not get an influenza vaccine, but what the data show is the higher risk people benefit more. And then lastly, I just want to say a few words, if you go to the next slide, about what I think is the closest thing to a vaccination for atherosclerosis to come. So this is something called Inclisiran. And this was just filed by to the FDA in December, I understand. This is a small interferon double-stranded RNA that inhibits the production of PCSK9, which, remember I said, increases your cholesterol levels dramatically. And if you go to the next slide, what you can see is that if you give patients an injection at baseline, 3 months, and then every 6 months after that, you are getting a sustained 50% reduction in LDL cholesterol. So this is very, very dramatic, right? There's no other therapy we know of that you can give twice a year and get a 50% time average reduction in LDL cholesterol. This is going to be designed to be administered in the doctor's office or by the pharmacist, and a large clinical outcomes trial has already started, but it's possible that this therapy will become available for an LDL cholesterol lowering indication, certainly before the cardiovascular events trial is finished. So next slide, and we're pretty much at the end. This in summary, we've talked about the recent guidelines and the focus on risk assessment and categorizing people into those at high versus not at very high risk. We talked about the newer therapies, not only the PCSK9s, but also pure EPA icosapent ethyl, which is now the first fish oil therapy to be FDA approved for cardiovascular risk reduction. And then also emerging non-statin therapies, and bempedoic acid is now FDA approved and will be out later this month, I understand. And we talked about Inclisiran as the possible closest thing to an actual atherosclerosis vaccination. So, and then finally, the newer, exciting diabetes therapy. So the last slide, I think, is this, to say being healthy is better than being sick and dead, the argument for prevention. And the last slide, thank you very much for your attention. And I'll be happy to answer any questions if there's any time left.
Thank you so much, Dr. Wong. This is Brian Wong, part of the RightCare initiative. At this moment, we're going to be unmuting our RightCare leadership, including Dr. Bommer, Dr. Ivy, as well as Hattie Handley, for any initial comments or feedback. At this time, we do invite participants to send in your questions that you would like to ask.
Thank you very much, Nathan, for a very comprehensive review of our best efforts at risk reduction. One of the things that we note on your slides is that even with our most impressive statin, PCSK9, and other ways of reducing cholesterol, those placebo curves still go up, and the treatment curves still go up, showing residual risk of as much as 50% still there. So we still have room to go, even though we've done a great job in reducing LDL with these newer agents. There's still quite a bit of residual risk left to deal with. And one of the other issues is compliance. The fact that with all of these great therapies and preventions out there, we still have 20% of our individuals at high risk taking advantage of these therapies and reducing their risk factors. Is there anything on the in the future that we think would be making that easier? Do you think vaccinations is going to be the way that improve compliance because you just come in once or twice a year for that?
Okay. No, I think these some of these advanced therapies certainly are really going to be targeted mainly to those at higher risk, but highest risk. But regarding your point about this residual risk remaining despite, all these therapies and how the event rates are still very high. One thing we have to keep in perspective is that all these trials that I've presented, remember, they are based on a single, except for that steno trial, they're based on a single intervention, right? So you are testing the effect of high intensity versus lower intensity statin, or PCSK9 versus placebo on top of stats. And so remember that there was no effort to optimize other risk factors. So the residual risk that you are looking at is basically, resulting from usual care from lack of other risk factors being treated. So if one, for example, further optimized in the placebo group, right, let's say the blood pressure, the A1C, as well as diet and exercise, you would have lower risk. So we always have to remember what I showed you with respect to diabetes is the problem and gap in multiple risk factor control. Okay, so some providers do great at managing lipids, but maybe they forget about the blood pressure, or vice versa. So we always have to look at the whole person and all the risk factors and make sure that they are addressed. Clearly, we know that from improved lifestyle and so particularly diet and physical activity, that we can get rid of 80% of cardiovascular disease. So this is why, healthcare systems, I think, need to better utilize the team-based approach that I mentioned at the beginning, right? So you seldom see, you'll see maybe one dietitian in a hospital for every 500 physicians, or, so we're not having enough of our skilled lifestyle interventionalists participate in prevention-oriented healthcare.
Thank you. Brian, do we have other questions in the queue from our audience?
Yes, we have one question. Do you consider pre-diabetes equivalent to diabetes mellitus for risk factor reduction treatment options according to guideline algorithms?
Yeah, so clearly that's a very good question. Clearly there are different targets and intensities of treatment recommended for people who have frank diabetes and those who just have pre-diabetes. So, for example, a statin, right, is recommended for everyone who has diabetes unless contraindicated, but not necessarily everyone with prediabetes. It depends on the risk. So this is why it's very, very important to do that risk calculator, and because prediabetes, like with diabetes, is accompanied by a wide spectrum in risk. You're going to have very low risk prediabetes people who may not have any other risk factors and who are very young. And then you'll have higher risk ones with multiple risk factors who really should be on a statin. So this is why always remember the beginning of the talk focused on knowing your patient's risk, and this could not be more true for somebody with prediabetes, because not one option fits all. We certainly do want to remind people of the diabetes prevention program, right, in people with prediabetes, where 150 minutes of physical activity and 7% body weight loss resulted in more than a 50% reduction in the incidence of developing diabetes, even more effective than metformin therapy. So lifestyle is clearly a key focus in someone with prediabetes.
Thank you, Dr. Wong. We also have a hand raised by Hattie Hanley.
Hi, this is Hattie Hanley, Director of the statewide RightCare initiative. And Dr. Wong, that was just a spectacular presentation. And I have to say, I did not realize that one of my favorite graphics of all time comes from your paper until we just heard you speak. And I have texted Brian to ask him to bring up that slide, which is your 3D slide of risk factors relative to coronary calcium. And I'm wondering if you can speak a bit more to that topic and how coronary calcium inspires patients to follow therapies, whether lifestyle or medication, more closely.
Yeah, okay, so I think maybe the 3D slide you're talking about was the event rates in people with and without diabetes and metabolic syndrome, right, and in relation to calcium scores. So that slide did show that there's great variation in risk. So not everyone with diabetes or metabolic syndrome is at high risk, but it largely depends on the amount of subclinical atherosclerosis, in this case coronary calcium, that was measured. But getting to your point about, is a picture worth 1,000 words? So we published one of the earlier papers on this in 1996 in American Journal of Cardiology, where we showed that people who had a calcium scan, and the higher the score, they were more likely to start cholesterol-lowering medicine, aspirin, follow a low-fat diet, stop smoking, even see their doctor, and also worry whether that's a good thing. So, and then there were other studies like the Eisner study I was also involved with at Cedars-Sinai that basically showed that people that got a scan and what they did with it were less likely to increase their Framingham risk score than people who did not get a scan. So the point is, yes, a scan can be very motivating because you're actually being shown where you have atherosclerotic deposits in your coronary arteries rather than just given a number, right? People, you tell people their actually blood pressure or even their cholesterol, and it doesn't stand out as much as really visualizing that disease. So hope that answers the question, and thanks for your comments.
Well, I definitely want to talk with you further after this about some other work that we're doing. And I also want to acknowledge that on the phone with us, we have leadership from around the state, including Dr. Carol Zaher, Dr. Eleanor Levin, Susan Ivey, and I won't take too much time on that, but this is such important information that you've relayed, and I wonder if we should open the lines for further questions if we don't have anyone in the queue.
Yes, we can do that right now. At this time, I will be unmuting our participants, and if they would like to speak some comments, they're invited to.
Nathan, this is Bill again. Do we have, when we look at additional things to the risk factor, coronary calcium score is clearly a very great predictor of events. When do you use coronary calcium? When do you turn to measuring CRP or LP(a)? How do you determine in which patients you'll go looking for those additive features based on additional testing?
Okay, well, that's a very good question. So if you go back to one of my earlier slides on the risk-enhancing factors, okay, so that was where in people who are at borderline or intermediate risk, this is where factors such as an elevated CRP, if measured, or an elevated LP(a) can help inform on the treatment decision, right? You'll see both of them are listed there if measured, okay? First of all, you want to really check the obvious things that everybody should know in a patient, right? Not only their ethnicity, but if they have certain inflammatory conditions, premature menopause, chronic kidney disease, metabolic syndrome, all these things are based on standard measures that people should be getting in the office and should be able to know if present. But then if measured, you're right, a high CRP means you're at higher absolute risk. A high LP(a) can be measured once because it's really genetically determined. What I didn't mention in my talk was that there is a very powerful agent to lower LP(a) in development now, may lower it 80% on average. And so that's another exciting development in the field. But the point here is that, you know, they always say if measured. So focus on the ones that you should have first, but, you know, if the main thing is you always have to ask yourself, whether it be with CRP or coronary calcium, is the result going to alter my approach to the patient? So if they are already on a high intensity statin because they have some of these other factors, then it's probably not going to alter your treatment decision, right? Because there's no guidelines that say, well, if you have a high calcium score, you should be put on a PCSK9. You know, we don't have that type of guidelines. So you always have to ask yourself, how is measuring one of these factors going to change my approach to treatment, right? And so that's the main point. And then it was really the calcium score, at least in the guidelines, kind of came later. In the guidelines, meaning that if you're still uncertain, despite the other factors being present or absent, then consider a calcium score. I think some of us, and I did see the very nice information on calcium scoring that's on your website, and I know that you know, Matt Budoff is part of your group as well. But you know, it certainly could be applied earlier. I think, you know, many of us, you know, feel that some of these other risk enhancing factors are not as predictive as a calcium score.
So I'd like to ask other people than Dr. Wong to please mute their lines. And would you please talk about this very favorite slide that you created that I use all the time? It took me so long to understand this slide, and I think if you talk people through it, they will understand it much better, more quickly.
Is it the one on the screen?
The one on the screen is just a spectacular piece of work. I don't know how you came up with it, but it is one of the most powerful slides I've ever seen.
Oh, well, thank you. I think you're being overly generous, but this, so this was a
to flatter you.
Okay.
I'm just saying that if you have all these risk factors and you have a 0 score, a calcium score, you should not be first in line in triage, for instance.
Well, the point here is that I think there's several messages that this slide can give. One message is that the amount of subclinical atherosclerosis is more important maybe than whether or not you have metabolic syndrome or diabetes. You could also put, instead of metabolic syndrome or diabetes, by the way, you could put LDL cholesterol levels there. You could put a number of risk factors there. You'd get the same thing, okay? Even if you have several risk factors, or if you're 75 years of age, you could put age there too instead of diabetes and metabolic syndrome. That even if you're 75 years old, if you have a 0 calcium score, your likelihood of an event in the next 10 years, this is why we call a 0 calcium score a warranty against the development of other events, is you have a warranty. Whereas a younger person like 45 or 55 who has a high calcium score, their risk is actually going to be higher than a 75-year-old with 0 calcium score. So you could put anything on that axis, but this particular slide is basically saying that you have a very low event rate regardless of whether or not you have diabetes or metabolic syndrome if you have a 0 calcium score. But if you have a 400 or higher calcium score, you have quite a high event rate. And a 2% per year, by the way, is about equivalent to someone who already has coronary disease. So we've kind of said, well, if your calcium score is 100 or higher and you have diabetes or metabolic syndrome, then you're basically at the level of risk as someone who already has coronary disease.
Thank you for this magnificent body of work, and I wonder if others have any final comments or so on, as we know we're at the top of the hour. Dr. Bommer?
I think, Nathan, we have to thank you for an excellent overview of the subject and a great direction for us. As you know, RightCare focuses not only on the science, but on the implementation. So we try to take this information and this data and release it to our healthcare providers in a way that our patients can actually benefit from the therapies that are out there. And you've given us a great direction, and we have a long way to go, as you can see from the data that showed only 20% compliance of complying with all risk factors, and clearly we realize that this has to be a comprehensive approach. We're trying that in the various cities that RightCare is in California, and we hope to expand upon that. The California Department of Public Health is on this call as well, and we're working with them throughout the state to improve the delivery of effective health care to the individuals in California in our overall effort to reduce the complications and events from cardiovascular disease. So on behalf of the RightCare leadership and of the Californians that you represent, we want to thank you for a great afternoon. And we want to thank all of our participants for tuning in on this first remote teleconference for RightCare. And we look forward to further events in the future. We'll probably be considering other transmissions like this. And hopefully everyone is doing well today, and hopefully we can avoid the complications of COVID-19 as they occur. So take caution, be careful. Thank you for joining us, and have a great afternoon.
And
thank you very much. It's been a real pleasure.
To Brian Wong, especially Brian Wong, for teaching us and bringing us along on this new technology. We love our digital native UC Berkeley graduates that have taught us how to have this statewide remote meeting. And thank you so much, Dr. Nathan Wong, for your magnificent presentation today.
Well, thank you. It's been a real pleasure and an honor participating with all of you, and I'm happy to help anytime, and love to learn more about the great things you and the RightCare initiative are doing.
Wonderful. Thank you so much. Bye now.
Take care. Bye.
At this time, we will be closing up the room. If there are any last comments or questions, you may send them to the RightCare initiative.
Thank you, Brian, and have a great day.
Thank you, Dr. Bommer, you as well.